occlusion, this is medial occlusion. The third movement is protrusion. Are you all with me? Clear. When the canine is guiding on the functional side, beyond the canine, I should have disclusion. Clear? That means no contact in this area. Functional side, beyond canine, if there is no contact, this is called anterior guided occlusion involving canine. My mentor, Dr. Stuart Otton-John, taught me that you don't use all these fancy terms, instead use the teeth that is involved in the guidance. That's the easiest way to remember. Canine guided. Canine guided. It is a canine guided, but it is an anterior guided occlusion scheme with canine as the guiding tooth. All the teeth are from here will be disclusion. Are you all clear? Yes. Okay, clear? So in any occlusion scheme, one rule is common. Non-functional side, no teeth should touch. Okay, non-functional side, no teeth should touch. Anything that is going to hit is an interference. And it is a dangerous interference. You all know that. Because functional side, the condyle will be rotating. Non-functional side, condyle will come downward, forward here, hanging in the muscle, hanging in an unstable position. When an interference, for example, if she is going to hit here. Okay, what is her name? Premolar. This premolar is sitting when the guiding is happening. This is called as a non-functional interference. Clear? This is very close to the condyle which is coming here. This will have a huge impact. The moment teeth contacts, muscle will fire. That will affect the muscle as well as the teeth. Non-functional interference are more dangerous. You understand? Go back. This is canine guided occlusion. For example, we have a patient where the canine is not placed exactly in the place. Go back. Lay belly placed. Go back. Go back. Lay belly placed. Lingually placed. No lingually. Lay belly placed. Let's keep it here. That will be confusing. Okay, go. Lingually placed. It is not in occlusion. It cannot guide. Okay? Still a premolar can guide. Still it is called as anterior guided occlusion. Anterior guided occlusion is nothing but it has to start as a single tooth. That is the logic. It can be a canine. It can be a only premolar. Only molar. Think about an open bite case from premolar to premolar. An open bite from second premolar to second premolar. This molar can guide on the functional side. Still it is anterior. Which is the only teeth which cannot guide 8. There is nothing to guide behind. Still 7, it can be a guided occlusion.
So you call it anterior?
Anterior guided. So when I say anterior guided occlusion, it's always anterior to PMJ. The only teeth which cannot guide is your 8. There is nothing to guide behind. Do you understand? Are you all with me? If this is open bite, this happens. But ideally, this is what happens. Canine will be guiding all the teeth, that is complete disclusion should happen. Complete disclusion should happen here. Understood about anterior guided occlusion? Okay, then go back. What do you mean by group function occlusion? Central, lateral, canine. Correct? Canine, come back. Now come. First premolar. Both the teeth are go back. Evenly come to one step. Evenly together they start. They start as a together they start the guidance. Okay, it can be canine with the first premolar. It can be canine premolar and the second premolar. It can be more. It can be all the teeth. So what do you call this? This is as group function occlusal scheme. Why? It starts as a group. In this also, beyond the guiding teeth, whatever area is there, this should be discluded. This is functional side. Then this becomes non-functional. All this has to be discluded. Understood? So a group function can happen between a canine and a first premolar. It can be all the 3 teeth. It can be 4 teeth. It can be 5 teeth. It can be 6 teeth. Even 8 also can guide. What is the logic here? Out of the 2 occlusal scheme, which is good occlusal scheme, an anterior guided occlusion involving canine is the best, because canine is designed by God in such a way you have a strong roots, good compact bone, exact position away from PMJ. So as a group, if it starts, it's called group function. If it starts as a single tooth, it is called anterior guided occlusion specifically.
Now supposing if canine is not there.
If canine is not there,
only from premolar it is starting also. That is also group function.
Yes, from premolar, if it is starting, if it starts as a single tooth, still I consider that as an anterior guided occlusion, right? If it starts as a group, then I will consider group function occlusion.
But canine is not taking part.
It's okay. It's okay. Canine cannot.
In that case,
yes,
the premolar load
100% it's a problem. That's why it's a ideal is canine. Many of your RCTs fail fractures happen in upper premolars, not because of RCT or access opening or pore buildup, nothing, it's because of occlusion. Premolar is the most abused teeth because the moment canine goes off, the entire load shifts to the first premolar.
And the first premolar is not designed to
Take up that load. 100% it cannot take up. It is compulsion. Any group function is compulsion. Okay, but I will use that compulsion at one cost. If this teeth all can guide to remove first molar to remove that, if all this teeth also let it guide, I don't mind. But if that can disprove that molar, non-functional side, I use any teeth here. Functional side, I can use any number of tooth, any occlusal scheme to disprove that. Do you understand? Okay, so what are the occlusal schemes available? Anterior guidance occlusion. Okay, involving it can be canine, up to the second molar, it can be anything. Correct? Next is the group function occlusal scheme. Did you understand? So here, all the teeth are guiding, no disclusion. Go back, if you come here, 3 teeth, you come, 3 teeth, you come. This is disclusion. Beyond the guiding teeth, disclusion should happen. Did you understand the occlusal scheme? Go back.
In same patient,
Yes.
two things can happen.
Yes, in the same patient, 2 things can happen. One side can be canine guided, other side can be group function. It can be anything.
So in group function, supposing if you have, say, let's say canine is not there or
Yes,
they've done a
yes,
mistake.
yes.
Now 4, 5, 6 are all in group function.
Yes.
Then that can withstand or that will also have a load on the premolar.
Thing is, group function occlusal scheme is a compulsion. It is not the best, it's acceptable. It's acceptable.
But if
provided non-functional is disputed because of this. That is my criteria, not this.
If
No.
that is touching,
That is touching.
then it is
No, if that is touching, then we need to plan something. I can use other teeth also to guide to dispute that. Or build the canine or involve the canine inside to dispute. Easy to build a canine and dispute easily because the anterior posterior. The moment it guides, it disputes at the back. Okay, this is about occlusion scheme. Go back now. So come canine, fast. You don't have time. No, only canine. Go back. Okay, you come out now. You come out, right? Okay, fine. You come out here now. Listen. Anterior guidance occlusion involving canine. This is functional side. This side only canine should lead, right? Okay, whatever that is hitting beyond the canine is called as functional interference. Okay, beyond the canine is the boss. Done. It should not leave the baton to anyone. This is called functional interference. At the same time, some other teeth is sitting there. That is called non-functional interference. You understood?
So that time what you will do? You will remove
Now, what I will do is treatment. Anything you can do. Okay, you can try to trim that, you do that, but you cannot touch the occlusion and MIT dentistry. No.
Supposing if canine
Yes.
7 is contact.
Yes. That is also functional interference.
That is not group function.
No. That's what I say. It should be continuous. That is where people make mistake. The moment they say premolar or molar, they say group function. No. If canine lives beyond canine, anything should be disclusion only. Come here. 8 is a functional interference. Go back. I'll give another scenario. Canine is guiding. Premolar. What do you tell? Canine should be the boss. The canine decides the extent of dynamic movement.
It's canine to canine if it touches.
Canine to canine touches.
But still premolar.
Till premolar is touching, that's a problem.
Crossover.
You get it. That's called crossover.
Then which is group function?
Yeah, group function is they start as a group. All 3 of you come together. They have to start as a group. So here the explanation is about what is the occlusion scheme. Anterior guidance occlusion, group function occlusion. Anterior guidance occlusion starts as a single tooth. Okay, group function starts as a group. You understood? Anything beyond the guiding teeth, either in anterior guidance occlusion or group function, is supposed to be an interference. If it also happens on the functional side, it's a functional interference. If it happens on the non-functional side, it's a non-functional interference. Are you all clear? Okay, listen. Then, 4th important movement. We have 4 incisors. All 4 of you come here. Ideally, I want this protrusive movement to happen only in the incisors, laterals and centrals. Okay, ideally, if this is guiding, exactly what I did is go a little bit of space. I need space on all the sides. Complete disclusion should happen on either side. Okay, complete disclusion. Christiansen's phenomenon. The moment you do this, that opening should happen. How much opening? One area may be more, one area may be less. That depends upon the shape of the condyle. That depends upon the glenoid fossa, the path traveled along the articular eminence and the glenoid fossa. Okay, I need disclusion happening. Now 7 come out, sir. 6 already you tried. Come here. Okay. These two are called as protrusive interferences. Clear? So if protrusive movement is happening, if something is sitting at the back, even a premolar is considered a interference. Even a premolar is considered as an interference. Huh? Maybe anything it could be. Anything it could be. Maybe the shape of the corneal is favorable there, the drop is more, here the drop is less. Anything is possible, right? But you should understand protrusive interferences are also dangerous. Because yesterday I told you we had a dance program yesterday, right? Okay, yesterday I told you non-functional is unstable. Think about what happens in protrusive. What happens in protrusive? The jaw is moving here. What happens to the corneal? The corneal has to come downward, forward. Still it is hanging. Translation. Correct? It is not unstable. So protrusive interference is also dangerous. Do you understand? Go back. All 4 incisors. Okay? Come back again. Only one incisor is guiding. Can we do that? If you put a veneer here, it will pop out. Okay? Why? Only lead guiding. What will happen? Have you ever come across a situation where it becomes non-vital? Looking good tooth, nothing. Suddenly non-vital, severe pain, primitus, one teeth jetting out. Classically, if you catch hold of that case initially, by taking an X-ray, you will have a funnel-shaped bone loss there. Classic sign of an occlusal disease, guiding single tooth. Even before RCT, also just have a thought of, see, looking into the X-ray, there is an angular bone loss. If you can share the guidance to the next central by adding a material or adjusting the material, at the risk of in the MIP dentistry, you can save the teeth vitality is good rather than doing a root canal. That is also there. Okay, so one teeth should not guide. 2 teeth always better to guide in protrusion. 90% of guidance happens only in the centrals, not in the laterals. Laterals are always placed somewhere here and there. The shape is not good.
So you would
Okay.
suggest putting veneers for the other.
Which one? No, there are many ways to do it. You want to correct this, you have to decide whether you want to have an approach of a MIP dentistry or a comprehensive dentistry. Both are there, no? The only choice what I have is, I have a choice. How to make this teeth guide? Tell me, lower incisor is untreated. If I have the option of adding a material in the lower, that is going to touch this tooth, which makes it a guiding tooth. Possible. Antagonist. Think about antagonist. If people are not thinking about antagonist, occlusion is all about antagonist.
So that diastema will.
No, forget about diastema. This teeth is guiding.
Yes.
This teeth is here, but the lower anterior is not touching her.
Yes.
That's why it's not guiding. Correct? That is at a lower level. MIP is achieved. Add a material here so that it touches. She also becomes the guiding. Possible. They are all.
Instead of reducing them, you
Add
add the lower.
Which is neutral English. If at all breaks, what will happen? The composite breaks. Let it break. Anyway, this teeth is going to break. Let a composite break. Who cares? That's easy, no? That's called interceptive occlusal management strategy, which you are going to learn tomorrow. Okay? Did you understand? So what all did we see? Occlusal scheme, anterior occlusion, then full function occlusion. Anything beyond the guiding teeth, forget about occlusal scheme. Anything beyond the guiding teeth is an interference. It can be there in functional side or non-functional side. And we have a third scheme called balanced occlusion. That is only for dentures, not for natural teeth. Go back. What is happening in balanced occlusion? Everybody look here. MIP. What do you do in MIP? What did I teach you? Huh? This is MIP. Standing. Come on. Ready? 1, 2, 3. This is MIP. Everybody come here, protrusive. When you come here like this, the entire teeth will touch on this side, in the center, there also. The entire denture will touch. Go back. In balanced occlusion, in protrusion also, all the teeth will touch. Okay? Now comes a difficult question. So, functional side, this side. All these are functional. Go sideways. Now you understand. Go side. All the teeth are touching in the functional side. Come here. Cross, and stand. Where are you coming back? Go back. Come here. So, all the teeth are touching in balanced occlusion on functional side as well as non-functional side. Same way happens when the movement happens here. The logic is very simple. Balanced occlusion, all the teeth will be touching on all the movement. That's why they call it as balanced occlusion. Is it really balanced? It's still flawed. There is nothing called balance. Enter bolus, exit. Enter bolus, exit retention. That is what they taught us in complete lecture. It's still a controversial topic. I don't believe in college. That's my call.
Sometimes in
Okay.
CE, they will upper 7 they tilt it.
Yes.
To give a balance.
We give their
Lower protrusion. The upper 7 alone will be tilted to give a balance. What they say.
whatever balance they do, not tongue is there, cheek is there. They do any occlusion is for a toss in a removable denture except cast partial. Remember, tomorrow I'll show you, if possible, I am telling my technician to hand over to access. If that is there, I'll show you cast partial also. How to play a set up. Cast partial is good, too good. More than RPD, cast partial is good. More than implant, cast partial is good. You think cast partial, don't hesitate to do. It's very, very good. Stability in occlusion will be too good in cast partial. If you select the case properly and if you do it. So this is about occlusion schemes. This is about interference. One example. Okay, you don't have to answer. Somebody from here can answer. Okay, go back. Sorry, come on. Sir, Ramal, sir, come on. Samira, you come on. What is this? Okay, you tell me exactly. Don't use the word canine gate. What is that? Anterior guidance occlusion. Functional interference, which is first molar. This is non-functional. Job done. Clear? Anybody has any doubt? Go back. Okay. Groove function involving canine, first premolar, second premolar. You cannot think like this and come, madam. Canine has to lead. You are the leader. Okay. Okay. You come out. Supriya, come out. You come out. 8. You tell me what is this? What is the occlusal scheme? First define the occlusal scheme. Groove function involving canine, first and second premolar. Functional interference on 8. Non-functional interference on 5. This is how you specify in your patient. Okay. So simply by looking into the picture or looking the picture, you will not see anything. How do you see this in the real mode? Put the paper, red paper. You have to make a dynamic movement. And you have to record it nicely. That's why occlusal indicator is the most important thing in occlusion where everybody struggles. That's why T-scan people make fun of articulating papers. Okay, what do they say? Immediately some picture is put there in the articulating paper mark. No, what we have been taught? More the color. I told you no, more the color. We say more the content. It's straight opposite. And when the patient bites like this, the ball of color bursts and the bonding agent sticks to the teeth. This is the logic of an articulating paper. So what is happening here? When the contact is more, the color is going to ripple away. The lighter the color, more the contact. It's straight opposite. That's why we treat something called bullseye. I told you, no? You put a blue color, you get a color. Then you put a red color. Because blue is very, very shabby color. It will mark more. Red will be more precise. Then it falls in. It's like a bullseye. Where you will have a blue color mark. Outside you will have a red. The red is the real contact. You have to adjust the red, not the blue. But we will be doing the straight opposite. This is about the occlusal schemes. This is about the interference. Class is over here. Okay. Any doubts in this occlusal scheme and interference? Yes.
Groove function involving canine, first premolar.
Demo, come here. Can I?
Second premolar and first molar. If second molar also comes there.
Go back. Second molar is. You tell me the answer.
No. First molar also. Is this groove function occlusion or is
What I am saying is you have to be very specific. What is guiding you?
canine?
Can I? First premolar, second premolar is guiding. Correct? It is a groove function. All the teeth are involved in. Groove function.
Sir, what if the second premolar?
Okay. I got your question. Go back. That is, you are taking me to, sir. They are slowly taking me to the fellowship, sir. Okay. Can I come out? This is the groove function. You tell me what is the groove function?
Yes.
Can I? First premolar, second premolar, first molar. Correct? Then what is a good groove function? What is good groove function is, as the jaw leaves like this, the molar has to leave back, go back now. Then the premolar has to leave. Then this premolar has to give and give the back end to this. Together they start, but towards the end of movement it should leave from back. Do you get it? If the reverse happens, it can end some interference.
Repeat, sir.
Okay, can I? First premolar, second premolar, first molar. All are starting together. Groove function occlusion scheme. Correct? So that means all the teeth should guide. Correct? So if the canine is living outside, still the teeth is touching, no? Who should be the leader?
Canine.
The final end should be the leader. The leader should be the canine. Right? Fine. So if it crosses,
Outside now, what you mean is?
that's crossover. So what I mean by living is, if this canine crosses, still the teeth are picking. To be precise, we call it as crossover interference. Once the canine crosses, it's an interference. The canine should be the last thing to stop. If it crosses and the teeth are hitting, crossover interference. Some people show that interference. They go from Kanyakumari to Kashmir. Have you seen such patients where they go like this? Very, very difficult.
Canine also went.
It go anywhere. You
She
understand?
also went.
She went no.
She also went.
She landed somewhere there. She was the next chair when I was checking. Okay, clear? Any other doubts?
Apart from first molars, ECO bucket cuspid.
Yeah, stop thinking about that. Sometimes we teach something and I have to break that content. Forget it. Okay, I'm also evolving, great. That's a 5-year or 4-year before we do.
So, canine first premolar, they are good function. Canine first premolar, basically. Second molar stays in. First molar coming. So she will be interference.
100%. How do you find it? How do you find it in articulating paper? Listen. You put a paper, articulating paper, ask the patient to move. How do you find it in the patient move? Can you go sit inside the bed and see who is leaving? Oh, are you madam? How am I? Are you leaving first? Then I Samira, are you coming next? We can't ask, right? How do you do?
So
You put a red paper, mark it. The canine will have a longer line. As it goes behind the line, the red line will become smaller. That tells me molar leaves first, premolar leaves next, next premolar leaves next. Canine is the longest one. That's why reading articulating papers is the best way to find out the interference. Your pictures are deceiving. One angulation of your camera will change it will show as if there is an interference. Plus the entire journey has to be focused. No, this is a snapshot, one shot. Everybody will say I am canine ready. Because end only you are capturing. But the entire journey, anywhere it can be, right? So these two are very, very important concepts when it comes to occlusal schemes and occlusal interferences. Clear? Done with this demo? You won't forget this again, no? Right? Okay.